Those of you who've come to the last couple of lectures, welcome back. For those of you who haven't, I'm Jamie. I am an F2 at Guy's Hospital. And I'll be talking you through the A to E, giving you a brief recap, but the focus of today will be on hypotension and reduced urine output. So, as before, we'll run through the A to E systematic approach just so that it's ingrained in your guys' heads as you go through med school and when you're on the wards doing your stuff as F1s and F2s. So the A to E is obviously very important. It's really good for critically unwell patients, but it's useful for any patient that you come across. It's a good way to keep calm under pressure. If you have a patient who is hemorrhaging in front of you or they're unconscious in front of you, it can be quite daunting, but the A to E is a fantastic approach to help get you through it, to both work out what's going on with them and what treatments they need. Be systematic, work through it in order, ABCDE, escalate early if you're concerned at all. Please get help, okay? If it needs to be a peri-arrest, if it needs to be that's not safe for the patient. And again, emphasis on communications, both with fellow medics that might be around, fellow doctors, but also the nursing staff on the ward. Clear communication as to what the patient needs quickly is absolutely vital. So as before, airway, first of all, look at the patient, listen, what are the noises? Are there any noises at all? Are they snoring? And if the airway is not patent or you think the airway is compromised, then get an anaesthetist there pretty quickly. You can do maneuvers, as we've spoken about previously. So that's the head tilt, chin lift, as well as the jaw thrust. And then you can use these simple adjuncts that you'll find on any crash trolley and on any sort of ENT ward. They'll quite often be at the bedside. So number one there is a oropharyngeal, a Goodell. You put it in upside down and then twist it as you put it in over the tongue. They're very easy to put in and they are very, very useful for a simple, to keep the airway open. Two is a nasopharyngeal, again, very, very useful. Probably used a bit less commonly than the Goodell, but still brilliantly. Just put them in like a nasogastric tube straight through the back. Just be wary, obviously, basal skull fractures, very, very rare and only typically in trauma settings, so you won't see them on the wards as much. Yeah, so basal skull fracture is a contraindication for a nasopharyngeal. And then three there is a iGel or an LMA, which is a more definitive airway. Anaesthetists use them intraoperatively quite often for short cases, and they're very, very good. And then last of all is an endotracheal tube, which will be put in by an anaesthetist and is a more definitive airway with reduced risk of aspiration because you can inflate the cuff. Okay. Breathing. So as we go through the A to E, we'll have a focus on hypotension. Okay, so obviously we've done shortness of breath and chest pain in the past. Different things are important depending on the presenting complaint. There's just a comment there. Can anyone hear it? Hopefully people can hear me. Yeah, there's a few people that can. So I don't know whether it's worth just quitting and coming back in if you are struggling to hear me. Oh, apparently the Facebook link didn't work, so try going through the Zoom app, guys, if you are struggling. I'll carry on if that's all right, just because we're a bit pressed for time. So Breathing, look at the patient. Are they blue? Are they tripoding? Are they using their accessory muscles? Do they look very out of breath? Okay, that is often one of the best signs to see whether a patient is in trouble. And then obviously your OBS, so looking at their saturations and their respiratory rate. Respiratory rate is a fantastic marker of any illness. Okay, if someone's respirator is up, something is typically wrong. Okay, and this respirator is something that's useful in hypotension as well. Okay, have a listen to their chest, percuss their chest. Just check the trachea is central and they've got bilateral air entry, and there's you know, both sides of the chest wall are expanding symmetrically. Otherwise, you need to think about whether there's something quite serious going on, such as a pneumothorax. Investigations, do a blood gas if they're hypoxic, an arterial blood gas, because it will give you a better reading, and also will tell you if they're retaining CO2, which is particularly common in COPD patients and can be very dangerous and life-threatening. But as a rule of thumb, if they're hypoxic, give them high flow oxygen, okay, because the hypoxia kills people first, not hypercapnia. But it is important to do an ABG just to make sure, and you can titrate their oxygen down as necessary. Get a chest x-ray to rule out proper major pathology, but also just have a look at, see if there's any consolidation or edema on the lungs. And do have a think about their escalation. Do they need sort of non-invasive ventilation, or do they need proper ventilation on an ITU setting? Okay. Circulation, this is probably what's particularly important during hypotension. So first of all, the OBS, which you have hopefully been given by the nurse, either over the phone or when you arrive, or if not, just do it yourself. Get an OBS machine, put a SAPS probe on their finger, put a cuff around their arm. Okay, you know, we are more than capable of doing that ourselves. We don't need a nurse to do that for us. And if it's going to make it quicker, it's for the benefit of the patient. Okay. So yeah, heart rate. Are they tachycardic? Are they bradycardic? Blood pressure, is it low? Obviously, we're talking about hypotension today, so it's probably going to be. Somebody's raised their hand. Go for it. I don't think you guys can talk. Just put it in the chat if you want to say something, guys. I'll be able to see it. I'm keeping an eye on it. Have a look at the patient. Do they look really pale? Do they have a look at their hands? Are they pale? Looking at their mouth for dry mucous membranes. And then examine them. So have a good feel of their pulse. Is it regular? Is there a peripheral pulse, or can you only feel it centrally? A bit worrying if you can only feel it centrally. What's their fluid status? If they're hypotensive and tachycardic, then they're likely to be underfilled. Oh, I can allow. Sorry, guys. I think someone wants to talk. Go for it if you've got a question. Angela? No worries if it was a mistake. Otherwise, just pop it in the chat, okay? Fine. Sorry, everyone. And then get an ECG on them. Very, very useful, okay, in all patients, particularly if they're tachy or if they're hypotensive. And then treatment. Once you get to the end of the C, get a couple of cannulas in, take some bloods off the cannulas, and give them some fluids if they need it, okay? And if they're overloaded, think about diuresing them, all right? D is disability. As we've discussed previously, the 4 I work through are just their level of alertness, so you can either use GCS or the quick AVPU if you want. Always get a BM, okay? You won't believe how many times people's symptoms are because they've hypoglycemic. Oh, fine, you raise your hand back, so that's fine. Because they're hypoglycemic, or if they're hypotensive and really dry, maybe they're hyperglycemic and they're in some sort of DKA. Look at their pupils, check they haven't had an intracranial event, and get a temperature for them. They could be septic. Finally, exposure. Do just head to toe, very quick systems examination. I just have a look at the head, work through, feel the joints of the body, particularly if they've had a fall, have a feel of their tummy, any wounds, any lines, any rashes, and then look at their limbs, check that neurovascularly they're all intact if there's any concerns there. Okay. After the ABC, as always, reassess if there's any changes or if you've given any treatments or if you're particularly concerned at any points, just start again, okay? Because A will kill you quickest, the airway, then B, then C, then D, then E, all right? And then have a bit of a better look about what's going on, why they're in hospital, look at the notes, review the drug charts, always look at the drug charts, okay? There might be causative drugs, there might be drugs that have been missed. There's always reasons. And then look at their bloods, do bloods, whatever, think about what scans they need. Consider their escalation status. Is this a frail old person who's multimorbid and is not for resuscitation? Is this a young fit person who we need to be talking to ITU quite urgently about, because they would be for everything, all right? And then just making sure that any investigations and bloods you send off, you follow up or you hand over appropriately. Okay. So hypotension today is defined as low blood pressure, as I'm sure you all know, typically lower than 90/60 systolic. That is the point we get worried, but completely dependent on the sort of body mass of the person. Okay, so larger people, taller people tend to run at higher blood pressures. Obviously, if they're hypertensive, they're going to run high anyway, so their hypotension might be a bit higher. And then on the flip side, very skinny young individuals might be walking around happy as Larry with systolic blood pressures of 95. Okay, so that's just always something to have in the back of your mind. Shock is where you get cellular or tissue hypoxia as a result of loss of blood flow. So there's actually 4 stages of shock that I'll talk you through in the next slide, and they increase in severity with each stage. But it tends to be when you can see the tissues aren't being perfused to an extent where there is cellular damage occurring, okay? And this typically presents with tachycardia and low blood pressure. And then low urinary output is obviously different to hypotension. It goes hand in hand, but there are multiple causes for low urinary output, of which hypotension and underperfusion of the kidneys is one of them. Okay, so it's also known as oliguria, and it's typically when you're producing less than 0.5 mils per kg per hour of urine, but that varies depending on the weight of the patient. Okay, just important to try and break down people's urine output by hour if you can, like get really strict monitorings, because someone might be anuric for 6 hours and that is actually a severe AKI, and it just because it hasn't been recorded doesn't mean that they are producing urine. Sorry, someone said ECG before bloods and BM. No, very good point. ECGs do always take a while to do. Okay, you know, I incorporate it in part of the cardiovascular thing so that when I get to see, I think, oh yes, let's do an ECG, and you ask one of the nurses, but it does take a while. So while you're waiting for that, by all means, carry on with everything else. Okay. So as I said, yeah, that's just from what I said in the previous slides. And oliguria has multiple causes, pre-renal, being hypoperfusion of the kidneys, typically goes hand in hand with hypotension, but oliguria can also be a result of renal disease, as well as post-renal problems such as obstruction of the urinary tracts. So shock, broken down into 4 different types of shock. Okay, so the first one is hypovolemic shock. Can anyone think of any causes of hypovolemic shock? Yeah, very good. Hemorrhage, bleed. Anyone else? Any other causes? It's obviously the most concerning one. Diarrhea, fantastic. What goes with diarrhea? Yeah, vomiting, good. So diarrhea and vomiting will cause hypovolemia quite often, and electrolyte balance. And yes, burns, fantastic. Whoever said burns. And yeah, dehydration, lack of intake. Okay, so all very good suggestions. Another one just to think about, if you're on a general surgical ward, that goes hand in hand with diarrhea and vomiting, is stoma bags. So particularly ileostomies can be very, very high output, producing 4 or 5 litres a day. And that's always something to be aware of if you see someone with a stoma. Okay, but yeah, you got all the main ones there. Cardiogenic. Someone said third space losses. We'll come on to that in a minute. Okay. Cardiogenic causes. What do people think? Yeah, MI, excellent. Yes, myocarditis, I guess, could. Yeah, heart failure, fantastic. Valvular disease, yeah. Good. Tamponade, interesting, we'll come on to that in a minute. And arrhythmia, excellent, so including bradycardia. Good, well done. Dissection, yes, can do. But actually, I wanted to speak to you about this because I said this last week. My case that was an aortic dissection presented with hypotension. A correction there. Typically, dissected patients present with hypertension. It's one of the main signs. Okay, and they'll quite often have radial delay as well, and differences in the blood pressures of each arm. Okay, distributive. What do we think about that? Yeah, excellent. Yeah, so you got the big ones there. Sepsis, anaphylaxis, neurogenic shock. Just checking I haven't missed one. Oh yeah, and pancreatitis as well. It's worth remembering. You get proper third spacing in pancreatitis, which is why they need so much fluid. Okay, and so whoever said third spacing for hypovolemia, not technically wrong. You are hypovolemic because your fluid is not in the intravascular compartments, but technically it's a distributive type shock. And then obstructive. What do we think? Yeah. So it's things. It's basically, as it says, it's blockages, and that's why, yeah, tamponade is one of them. So it's things blocking big vessels, so like PEs, or it's things blocking the heart itself, so like a tension pneumothorax or a tamponade compressing on the heart, meaning the heart can't pump blood effectively, is an obstructive type picture. Okay. Fine. Oh, where have my... Oh, sorry, I skipped past this slide. So yeah, these are these 4 stages of shock. Okay. So stage 1, you're thinking, hang on, this patient might be there might be something grumbling away, but actually, particularly if they're young, they will compensate very well. And typically their obs are fine. So you can see here, pulse rate, blood pressure, rest rate, all normal. Okay. So it's worth having the back of your mind that people can be in shock and seem actually all right. Okay. Stage 2 shock is 15 to 30% of blood loss. This is for hemorrhage, obviously. And you tend to get tachycardia without hypotension. Stage 3, you get tachycardia with hypotension and a bit of confusion as well. And stage 4, you're getting proper tachycardia with severe hypotension. Often their GCS is dropped quite considerably, and they've lost a big amount of blood. And the way I remember the percentage blood losses there, guys, is just like a tennis game. 15 to 30, 30 to 40, and then obviously greater than 40. Okay, so useful tip there that you might like. So how are we doing for time? Perfect. Let's go on to some cases. I've got 3 cases like before, because I think it's a good number. I don't want you guys to be here for too long. You know, I think quick 45, 50-minute sessions tend to work well, just to make sure that everyone's tuned in. So hypotension we're thinking about here. You've been bleeped by a nurse. It's a patient on the Jerry's ward, and she's 78 and she's got a temperature of 38.8. So you're on the phone to the nurse. Obviously you're going to try and get some more obs, thinking about you know, why is she spiking fever, and how worried am I? And they say, actually, let me just move the chat out of the way, sorry. Yeah, her blood pressure is 84 systolic and she's got a heart rate of 106. So I hope after these couple of sessions, we're all thinking, actually, yeah, I'm a bit worried about this person. So at this point, I would ask the nurse to make sure we've got a full set of obs, and check the SATs and everything in time for when you go and see them straight away, and ask them to get stuff ready for like cannulas and things, because they'll probably need it. Okay, and it just saves you time once you're there. So you go and see her. She's lying in bed. She's quite comfortable actually. She seems in a bit of pain, but you do your ATE. Airway is patent, the trachea is central. Okay, there's no strange noises. Breathing, saturating just about fine on room air, and her respirate's 25, and she looks a bit out of breath. Okay, but she's maintaining her SATs, which is good. And you have a listen to her chest, and it sounds all normal. Okay, going through circulation then. Looking at her obs, she is tachycardic and she has a blood pressure of 84 systolic. Her cap refill time is 4 seconds, so it's a bit delayed. It's double what it should be. And she feels a bit cool peripherally, particularly in her fingers. Okay. So at this point, I would be thinking, right, we need to treat what we can treat right now before moving on. So I'd get a big cannula, ideally 2 if there's more of you around, but get at least a pink, but ideally a green somewhere, preferably proximal to the hands. But you know, if you can't get a vein, then you know you have to do what you have to do, and hand veins are also very useful. Nope, fine. So any cannula you put in, take some bloods from it. Just get a big 10-20 ml syringe and just pull off all those bloods, and you can send them off later. And then she's hypertensive, she's going to need fluids. So I would give, she's elderly, I'd probably just give a 250 ml bolus of saline, just stat, and see how her blood pressure responds. See if her tachycardia responds as well. She'll probably need a couple of them, particularly if she doesn't respond after the first one. If she's not responding to fluid boluses after 2, or if it's dropping, that's when you need to start getting worried and escalating quickly, or if they're becoming more tachycardic. Okay, but typically they will respond. Okay, patients are very good at responding to fluids. It's a very useful drug. So get those through, but while they're running through, they tend to take sort of 5-10 minutes to run. You can carry on with the rest of your assessment. Okay, so going on to D, disability, we're looking at a GCS. She's a bit confused. She's sort of she's only opening she's opening her eyes to everything, but she's only using one word answers for things. You don't know whether that's her baseline. It could well be, but you know, that's all you can get at that time. Useful to get a collateral from the nurse if they're there. And temperature of 38.8. Okay, so we've got a hypotensive tachycardic patient who is febrile. Okay, what's our main differential? Sepsis. Thank you very much. Sepsis is by far the most common thing. Okay, you'll see it on the wards all the time. All right. We'll go through a couple of definitions in a minute. But there and then, what do you need to do? Yeah, blood's very good. People who said full blood count, CRP, U&Es. Yeah. If you're worried they're bleeding, send off a group and save and a clotting as well. Yes, sepsis 6, fantastic. Hopefully it's ingrained in your heads. We'll go through that in a minute. But then just moving on to E, what do we want to do? What, you know, we've got a septic patient, great. What do we need to know more about them? Yeah, exactly. What's the source of the infection? Fantastic, okay. And most commonly on all wards, it'll be urine or it'll be chest, okay. But you've had a listen to the chest and it's clear. Have a feel of the tummy. There's no suprapubic tenderness. She can't tell you about dysuria, but there's no catheter in situ, and she's got pads, but they don't. There's no foul smell or anything. And then, so you think about other sources. What other sources of infection can we have? I think someone said a couple up here. Yeah, so skin rashes, very good. Wound infections, scars. Yeah, so always look at wounds, see if there's any wound infection. Rashes, particularly worried about meningitis. If she's drowsy, she might not be able to tell you that she's got a headache. What else have we got here? Cellulitis, fantastic. Yeah, particularly in an older person. So typically look at the legs. All right, obviously they can get cellulitis anywhere, but look at the lower legs. That's where they tend to have them. Infective endocarditis, great. Have a listen to the heart. Can you hear any murmurs? Again, and it's one of those endocarditis that you're not going to pick it up straight away. It's a difficult diagnosis that you need an echo for. But by treating sepsis using the sepsis 6, you will be able to start them on treatment that they need. Okay, and you can go into it a bit later. Dengue fever, interesting. I mean, yeah, all tropical diseases can cause sepsis. So yeah, very important to have in the back of your mind. Particularly if you work somewhere, obviously if you're working abroad, but if you're working in London particularly, I think the tropical medicine center is at UCLH, so you know, you don't know what you might see. And yeah, abdominal sources, very good. So yeah, you guys have nailed all of that, and you have a look and you do. She doesn't have a headache, there's no visual changes, no photophobia, no neck stiffness, chest is clear, there's no obvious cellulitis in the upper arms, there's no murmurs, there's no history of diarrhea or foul smell of urine, can't see any rashes. And you look, finishing your examination, you look at the lower legs and they're both bandaged up, and it's likely that she's got horrible venous disease and has had it for a long time. And you undo the bandages, have a look, and they're pretty foul smelling cellulitis. Typically it's only in one leg, cellulitis, but you can see it in both legs. I've seen multiple patients who've come in from A&E and they've actually got maggots in their legs. Lots of diabetic patients just don't, they lose the feeling. And just because it's cellulitis, it can be life-threatening. It is sepsis can promote a big inflammatory response. Okay, so you need to treat it seriously, and that's why we use the AD approach. All right, so here we go. Sepsis is your host response to an infection becomes causes life-threatening organ dysfunction. Okay, it becomes dysregulated. It's not routine. It's everything is it's a big cytokine storm, and that's what is dangerous, and that's what kills people. Shock is where you get circulatory abnormalities, as in this patient who is hypotensive. And sepsis 6. So I'll answer your question in a minute. Very good question. Sepsis 6. So we are going to give them oxygen. So give 15 liters via non-rebreathe mask. Even if their oxygen's normal, they typically will need oxygen. Okay, because in sepsis you're in a very much catabolic state. So your tissues will become hypoxic eventually. Okay, so oxygen is very useful. Give them IV fluids, as we've already done, and once you've bolused them, if they've responded, then they'll need further maintenance fluids. Just be wary if they've got any heart failure once you've given an initial bolus. What else are we giving? Broad spectrum IV antibiotics, I think, as you all said. So there are trust guidelines. Follow your trust guidelines, but typically it'll be something like IV tazocin, and if they're allergic, IV meropenem. And if you're suspecting a source such as meningitis, you can give ceftriaxone. If you're suspecting a urinary source, you can give a stat dose of gentamicin, but follow your trust guidelines. And then you take what do you take? You take a lactate, so do a gas at some point. Once you've given the fluid boluses, you need to treat them if they're unwell first, but do a gas to see how bad their lactate is. You need to take their urine output as well. So often putting in a catheter is very useful because you need to monitor their fluid balance very strictly. And the last one, sepsis 6. What else do we take? Blood cultures. So yeah, you took the 20 ml syringe. Just send off some cultures. Okay. Yeah, VBG, Paul, as you said, they weren't hypoxic, so you can a VBG is very much fine, and you can take it from that syringe you took. ABG if they're hypoxic. So someone said you've been discouraged by your consultant to write bilateral cellulitis. Does this exist? Very good point. Yes. 9 times out of 10 cellulitis is unilateral. Okay. But in patients with really bad venous disease that requires bandaging and they're really weepy, you can get it in both legs. Okay. It is something that a lot of people hate, but it is a possibility. Okay. But typically it is only unilateral. Okay. Fine then. Case number 2. You get a bleep from the nurse. Let's say it's 10 p.m. at night and you're on your first night shift. And she says, "Oh, doctor, I'm quite concerned about this patient. They look, their face looks a bit puffy." Yeah. So I said looks a bit puffy there. Sorry. Yeah, mainly face. Sorry, heart failure, fluid overload, renal failure, very good. But yeah, face is puffy. Good. Anaphylaxis, allergy, all along the right lines. Okay. What would your first question be to the nurse, do you think? Yeah, good. Yeah. What have we eaten? What have they had? But what I would want to know is this patient stable? Okay. Are you worried about this patient? And if the answer is yes, then you need to get your running shoes on and make your way there as fast as you can. Okay. Because if this is anaphylaxis, and I have still never seen an anaphylaxis, I've seen them once they've come in and been treated by the ambulance, but I've never seen one on the wards or had to treat one, touch wood. Okay. But I think it probably is the scariest, one of the scariest emergencies that you might have to deal with. Okay. But use the AIRWAY approach. use the guidelines, and actually it's very treatment respondent. Okay, so A to E, you go and assess this patient. They look puffy lips, and their airway, there's some very loud, strange noises as they're breathing, and their rest rate is quite high, and their SATs are sort of 84. Okay, they look very unwell. What's the first thing you're going to do? Yeah, secure the airway. Fantastic. Okay, so you can use airway adjuncts or airway maneuvers. There'll probably be alerts. They won't tolerate airway adjuncts, so I would just use maneuvers. Okay, and lying flat can help them. 15 liters, non-rebreathe, oxygen mask straight on their face. Okay, hypoxia is very severe in anaphylaxis. Okay, and then yeah, IM adrenaline. I completely agree with that. The only caveat is what I would say, ask the nurse or someone else to get the IV adrenaline and then put a peri-arrest call out as quickly as you can. Okay, or get someone else to put a peri-arrest call out, because if their airway is compromised, all right, you can't be dealing with this on your own. You need to sort that out. Okay, so always have in the back of your mind, I need to get help if I'm in trouble. Okay, and this is a very reasonable one. And if you're convinced it's anaphylaxis, okay, and you're properly worried about this patient, you can put a cardiac arrest out. Okay, because people get to cardiac arrest quicker than peri-arrests. All right. Fine. So treatment, yeah, excellent. What have we said? So we're giving oxygen, but what they need is IM adrenaline. Okay, and it's 1 to 1,000 is the concentration of adrenaline, and you're going to give 0.5 milligrams or 500 micrograms. Okay, and just to say, the concentration is different to what we use in cardiac arrests. That's 1 to 10,000, not 1 to 1,000. Okay, so just make sure you know that that they're both separate. Yeah, so that is the most important thing. Okay, the other two drugs that we use are IV hydrocortisone 200 milligrams and chlorphenamine 10 milligrams IV. Okay, now chlorphenamine is good for helping symptoms of allergy, but it doesn't really help with the angioedema as such. Okay, with like reducing the swelling, which is what's going to cause airway obstruction. Hydrocortisone, anyone know how hydrocortisone acts? It's a steroid. Don't worry, I'm not expecting you to. Okay. Yeah, it works on the immune system, fantastic, but actually at a cellular level, how does it act? What does it act on? Yeah, it reduces the immune response in a number of ways. You're all correct. But the thing that everyone needs to know about steroids is they act on intracellular receptors, okay? They do not act on extracellular receptors. And that then causes a cascade which interferes with transcription and translation of mRNA and therefore proteins, okay? That process all takes time, okay? So in an acute scenario where you have an anaphylactic patient in front of you, yes, IV steroids, you need to give them as quickly as you can, but in the first few minutes, in fact, first hour or so, it's not going to help, okay? What will help them, what will save their life is adrenaline, okay? So you give the 0.5 milligrams of adrenaline, 1 to 1,000, and then as part of the A to E assessment, absolutely, okay? They have got an airway compromise, you need to treat that. And the treatment for that airway compromise is adrenaline, okay? Very good question though. And then if they don't respond, what do we do? If there's no response to adrenaline, you've put an arrest call out, people are on their way to help you. You are supporting the airway, they've got oxygen flowing. Yes, repeat. And you repeat after 5 minutes, okay? And you can keep repeating after 5 minutes. If this is proper anaphylaxis, you can keep repeating. Yes, they may need intubation if it's really severe and they're not responding, but that is not your call. That's up to the anaesthetist. Now, if they are not responding to adrenaline, and this is rare, okay, some people will take a couple of doses to respond, particularly if it's severe. The treatment that you can do is an adrenaline infusion, okay? So while before we were giving stat doses IM, intramuscular, just on the anterior lateral thigh, as someone well said, you can give an IV infusion, but again, that won't be up to you. That'll be up to registrars, consultants to decide, okay? Now, what is the most, I've said a lot of things are the most important thing in anaphylaxis. I do appreciate that, and apologies. But something I haven't said, which is part of the treatment, that is vital. And you'll know when you get on the ward, you'll know to do it. So it's stopping the causative agent, okay? Typically, it'll be an antibiotic that is infusing. And there might be some co-amoxiclav running over sort of 20 minutes, and turns out they've got an anaphylactic reaction to penicillin. Okay, get that out, get it out, get the whole cannula out, and stop the source of what's causing the anaphylaxis. Okay, very good. Any questions? Put them on the chat. So here is the updated 2021 Resus Council guidelines, quite a simplified version. Would you put in a different cannula? Yes. Okay. So the good thing about adrenaline is that you can give it IM, so you don't need a cannula. If the causative source is a penicillin or a drug that is running through that cannula, just take the cannula out. Okay. Anyone could put another cannula in. You've got a whole resus team coming if you can't. Okay. 1 to 1,000. What does it mean? It's just the concentration of adrenaline in the liquid that it's in. Okay, I can't remember the exact dosing, but it's more concentrated than 1 to 10,000. So these guidelines, as we've been through, the main things that they say are call for help, remove the trigger, lie them flat. You can lift the legs up if you're worried. And then, yeah, so once the adrenaline's gone in and they're slightly responding, keep going with your ABCDE. Okay, go on to C. They're probably going to be hypotensive. They're going to need a cannula. They're going to need fluid bolus, followed by more fluids. Take some bloods. I think is it antitrypsin, I think, is the blood level that they like. The allergy team. So if you remember to do that, brilliant. If you don't, it's not the end of the world. And at the bottom, it's just got the doses of adrenaline in children, which is, again, worth knowing. So perfect. Oh, someone's put on the Q&A, sorry. Do I use the SIRS criteria or the Q SOFA for the diagnosis of sepsis? Yes, they're both very useful tools. And they really are. They are very good. I can't remember them off the top of my head, I'm afraid, but well worth looking up. So that's the SIRS criteria and the Q SOFA. They're really quick ones. And you'll run through the criteria within your A to E assessment, okay? Which is why I typically don't use them. But they are fantastic parameters to know about for diagnosing the severity of sepsis, okay? Let me just get rid of that. Fine, moving on. Last case. We're doing well. Yeah, this one will be quite a quick one, actually. So you get bleeped by a nurse on the general surgical ward, and he says that there's a 75-year-old man here who's looking a bit pale, and I'm a bit worried about him. What do we do? As we've spoken about on the phone, try and get a bit more information. Why is he here? And what are his observations? And he's able to tell you over the phone that his heart rate's 110, but they can't get a blood pressure reading at the moment. Okay. And that's a bit concerning. And then you say, what did he come in with? What's his problem? And he's come in with PR bleeding yesterday. Okay. So are we worried or not worried about this man? I mean, you can see the A to E assessment already there. So I think it should be hopefully quite apparent that we are quite concerned about this gentleman. Good. So you get there, A to E. Airway, unlike the last chap, is patent. I think it was a man. It's patent. Trachea is nice and central. They're sat to 90 and their respirator's a little bit up, but their chest sounds clear. Okay. Circulation from the end of the bed. This guy looks pale. He looks white, and he looks uncomfortable and in a bit of discomfort. Cat refill time is 6 seconds. You get the obs. They finally get a blood pressure at 64 systolic. Okay, and the heart sounds are present. But when you get those blood pressure readings, what are we thinking? Let's say this guy already has a cannula. At that point, there, I would immediately get some fluid in him. Okay, because that is way too low. Good. There's some suggestions about bleeding on the chat. Very good. That's 100% at the forefront of your mind. And you are thinking about where the bleeding is coming from, if he is bleeding at all. But if he's pale and he's come in with bleeding and he's hypotensive and tachycardic, the chances are this man is in hypovolemic shock secondary to hemorrhage. Okay. So what fluid would I use? Very good question. Just a bonus, I just give normal saline. Okay, 250 mils stat, normal saline, and then another 250 mils. If you think that this man is bleeding, try and find the source, because if you have proof that he is bleeding, then you can put out a major hemorrhage protocol. Okay, and you can be more reassured about doing it, because putting one out is a bit scary. It's like putting an arrest call out. Okay. So I look quite quickly for sources of bleeding. So he's on a general surgical ward. Where would you look for blood? Yeah, floor and 4 more. Very good. So areas that you typically bleed out are the floor, as someone said, intra-abdominal, intrathoracic, and long bones as well. Okay. So yeah, those are the ones. But if he's on a general surgical ward, we're probably thinking that he's going to have bled from somewhere in his tummy. Okay. So thinking about mouth, has he had any hematemesis? Let's say in this case, no. Has he got any surgical wounds that are bleeding? Has he got any drains that are bleeding? Okay, let's say he doesn't, but he's come in with PR bleeding, so he's probably bleeding from his back passage. Have a look. There'll probably be blood all over the bed. Okay, I haven't seen a case this severe, but my friend has, who I was working with in my last job, and it's just loads of blood. Okay, and it is really quite scary. And you can do a PR if necessary. Absolutely. I would. Any pale patient who's hypotensive, do a PR. Okay, you need to rule out that they're not bleeding from their back passage. Okay, but this guy's got a big PR bleed. Fine. So at this point, we need to think about the cause, but we need to think about, more importantly, how we're going to treat it. And the mantra that people have is replace blood with blood. Okay, so if he's bleeding, he needs blood. So he might not have a cross match, he might not have anything ready, he probably won't. So put out a major hemorrhage protocol, 222 major hemorrhage protocol, saying the floor that you're in, the ward that you're in, and if it's an adult, if it's for an adult that you want, typically that's for arrest, but just do it anyway. And say that you need as much blood here as quickly as you can. Okay, and once it gets there, just run those red cells through. All right, there'll be O negative, rhesus negative blood, and that'll help. While the blood is coming, you are by all means welcome to replace the intravascular losses with fluid, okay, to just try and keep that blood pressure up. That's absolutely fine. And the other thing, if this guy is bleeding like this, you need to put a peri-arrest out as well. Okay, you need anesthetic support there as quickly as you can. You need a med reg there as quickly as you can. And you need to bleep your surgical registrar as well to get them there as quickly as you can. Because we don't know where this blood is coming from. Maybe the diagnosis is known already, but quite often it's not. So we need to think about stopping the bleeding, okay? And you just, again, simply work through your AT, make sure you complete it all, take the bloods off, send them for proper group and save, cross-matching, get a coag as well, because this guy's likely going to need not just red cells, but FFP, and probably some platelets as well, just because his coagulation will go all over the place if he's bleeding this much. Will he peripherally shut down? If so, will he be difficult to cannulate? Should we consider IO? Very, very good question. Yes, he will likely be peripherally shut down. He might well have a cannula in, okay? It's quite rare that you see a patient, on a general surgical ward who's got PR bleeding that doesn't have a big cannula in. If he doesn't, try anywhere you can get a cannula is fine, okay? This man needs fluid, needs blood. And if you absolutely cannot, that's why you put the peri-arrest out, because more senior people will come to make the decision as to whether they can try, and an anaesthetist might need to put a central line. And I've seen anaesthetists at resus calls just put a green cannula in a neck vein because that's what they can see, and that's fine. But you need experience for that. And but you're very, very well to say, can we consider IO? IO is a really useful tool. I've never seen it used on the wards. It's typically used in resus in A&E. And also mainly in children who are quite difficult to get vascular access from. So children involved in trauma calls are the classic who would get IO, but it's a useful tool and should be used if you can't get access, quite right. Yeah, it's upper tibia. So if everyone feels their tibia, just below the patella, you can feel the tibial tuberosity. There's a flat part just medial to where the spine of the tibia runs, quite proximally. And so there's a flat part, forms like a triangle there. That's where you tend to go with the drill. I've seen one done in resus. I've never done one myself. Okay. Cool. What else was I going to say about this man? Oh yeah, cause of GI bleeding. So I'm going to do in my last session. So I've just told Azim I'll do 4 more sessions after the next one, so 8 in total. My last one I'm going to do on upper GI and lower GI bleeds. Okay, but just because this case has cropped up, causes of PR bleeding, as I think a few people have suggested. The concerning one long term is malignancy, and then thinking about polyps and ulcers alongside that. Hemorrhoids cause fresh red blood, typically not a lot, but an amount of fresh red blood that's visible in the bowl or on toilet paper. Ischemic colitis can produce a lot of blood, and quite often it's mixed in with stool and goes hand in hand with a severe episode of diarrhea and abdominal pain. The patient's likely to have had clots in the past and may well have AF, so worth doing an ECG on them. Diverticulitis, often in the past medical history, their inflammatory markers will be raised, and they'll have probably have a bit of diarrhea as well, and some left lower quadrant abdominal pain on palpation. Angiodysplasia is a really, really tricky one. It's due to sort of arterial malformations that basically rupture spontaneously, and you get a bright, fresh red blood and a large amount. And this case was an angiodysplasia. And yeah, with that go AV malformations, as someone has correctly said. Upper GI bleeds, they can, but you know, it's normally melena and dark stools that is foul smelling and mixed in with the stool. It is quite easy to differentiate from a lower GI bleed. And then IBD, so UC typically, but can be Crohn's as well. When they've got ulcers, can bleed. And radiation, if patient's been treated maybe for rectal cancer with some radiation, that can cause inflammatory process within the rectum that can cause bleeding. So how do you diagnose angiodysplasia? Good. Yeah, sorry, you wouldn't have got it from that history, don't worry. I was just using a case from my previous trust. So it's very difficult, and you need to try and have these in the back of your minds. Yeah, you can do colonoscopy, but if you're unsure, it can be quite dangerous, particularly if they might have a flare of diverticulitis, because you can get false lumens. So that's worth discussing with the surgeons and the gastro guys. If they're actively bleeding bright, fresh red blood, and they're hosing it out, and you've managed to stabilize them with units of red cells, what investigation can we do? Does anyone know? Flexi, yeah, like a colonoscopy, quite often is not the best urgently. So it's a CT angio. And quite often you can see if they're actively bleeding, it's somewhere along the colon, one of the colonic vessels from one of the main three trunks will be bleeding. Radiologists hate you requesting CT angiograms because 95% of them, you cannot see the source of bleeding because they're not actively bleeding. It's only useful if they're actively bleeding. Okay. Abdominal x-ray, good suggestion. Yeah, agree. Just check they haven't perforated. Get an erect chest x-ray as well. Cool, so that's that. Any questions? Fire them on the chat. Could you give tranexamic acid? Yeah, so tranexamic acid, sorry, I didn't say, is part of the major hemorrhage protocol. And it comes with a big leaflet. And I think, I can't remember the dose, I think it might be a gram, but I'll look it up. Of tranexamic acid is very, very useful to stop bleeding. Okay. So yeah, any questions, put them in the chat. Otherwise, there's the QR code. We both of Zoom and I very much appreciate your feedback, guys. It's really, really useful.